Hey there, it's Laureen Lawlor Smith from Low Carb Keto Health. This is a presentation on cholesterol. Cholesterol is an essential fat without which we wouldn't exist. It's also been around for a very long time. Cholesterol has been isolated from fossils of Dickinsonia. Dickinsonia is an example of one of the earliest forms of animals in our evolutionary history. Cholesterol is thought to be important in terms of the capacity of single-cell organisms to evolve into multi-cell organisms, and also in terms of the capacity of species to be able to survive in increasingly high oxygen environments. Cholesterol has a number of really important functions in the body. Firstly, it's vital for cell membrane structure and function. It's essential for brain structure and function. 25% of the total volume of cholesterol in the body is in the central nervous system, including the brain. Cholesterol is so important to brain function that many brain cells can produce their own cholesterol. Cholesterol is a precursor for vitamin D. Cholesterol particles underneath the skin, activated by ultraviolet light from the sun, can become vitamin D. Cholesterol is also a precursor for a number of important hormones, including cortisol from the adrenal glands, estrogen, progesterone from the ovaries, and testosterone from the testes. Cholesterol is important for the production of bile acids. Bile acids are manufactured in the liver. They're secreted into the biliary tree and stored within the gallbladder. When eating occurs, especially when fatty foods are consumed, the gallbladder contracts, secreting bile into the upper small intestine, and this breaks down or emulsifies fats and allows for the absorption of both fats and fat-soluble vitamins. Another form of fat in the body which is important is triglycerides. Triglycerides is the form in which fats are transported around in the body and also stored in the body. Triglycerides consist of a glycerol backbone together with 3 fats or 3 fatty acids. Fats do not dissolve in water. You cannot transport fats around in the bloodstream just as fats because they form fat globules. Fats instead are transported around in the body as lipoproteins. Lipoproteins or fat proteins are manufactured mostly in the liver, but also in the small intestine. A lipoprotein consists of an outer layer of phospholipids and cholesterol, which allows the lipoprotein to dissolve in water. Each lipoprotein has a specific protein attached to its surface, and this allows the body to recognize which lipoprotein this is and what function it is. And the core of the lipoprotein consists of both triglyceride as storage fat and also cholesterol. Lipoproteins are divided up into various forms of lipoprotein, and you consider it like a delivery system where some of the lipoproteins are involved in delivery and some of the lipoproteins are involved in returns. So LDL is involved with the delivery of both fat, cholesterol, and triglycerides throughout the body. So a low-density lipoprotein is manufactured in the liver. It's secreted as a very low-density lipoprotein. As it goes around the body, it offloads its triglyceride and cholesterol. It becomes smaller and denser and becomes a mid-density lipoprotein, releases some more of its cholesterol and triglyceride, becomes smaller and denser, becomes a low-density lipoprotein. And this whole process continues with LDL becoming smaller and denser until ultimately the liver recognizes it. There's a receptor on the liver that recognizes it. It gets taken up into the liver. It loads up again with more cholesterol and triglyceride, and off it goes again. The protein attached to LDL is called apolipoprotein B100, or ApoB for short. HDL is involved with returns. So HDL is the particle which picks up excessive cholesterol and triglycerides and returns it to the liver. So HDL is excreted from the liver as quite a small particle, and as it's going around, it gets larger and less dense until ultimately it is recognized by a receptor on the liver. It gets taken up, it offloads its cargo of cholesterol and triglycerides and gets secreted out into the system again. The protein associated with HDL is called apolipoprotein A1. Lipoproteins have a number of other significant functions. They're involved in the transport and delivery of fat-soluble vitamins. In immunity, together with white cells, lipoproteins are involved in preventing the body from being infected by bacteria and viruses. Lipoproteins deliver antioxidants to the body, including coenzyme Q10 and beta-carotene, and lipoproteins are essential for cell repair. Let's have a look at the association between lipoproteins and myocardial infarction or heart attacks. And for the remainder of this talk, I'll be referring to heart attacks as coronary heart disease. This is quite a large study of 384,000 UK residents, followed up for a mean of approximately 12 years. And we've got the hazard ratio for coronary heart disease, and we've got the level of LDL cholesterol. And you can see until LDL cholesterol gets up to about 4, there is no association between coronary heart disease and LDL cholesterol. But as soon as you get to a cholesterol of roughly 4, you can see as the higher the LDL cholesterol, the higher the risk of coronary heart disease. We have a look at HDL. There's a very different pattern. From cholesterol, as HDL cholesterol is above 2, there doesn't seem to be an association, but below 2, there is an increasing association with HDL cholesterol and coronary heart disease, with the lowest HDL being the highest risk. So this is the level of the current consensus about lipoproteins and coronary heart disease. It is believed that LDL is associated with increased risk of coronary heart disease. And the higher the LDL, the more problem you've got. And that HDL, low HDL, is associated with increased risk of coronary heart disease. So, in fact, it is believed that LDL cholesterol causes coronary heart disease, and that you should push LDL cholesterol as low as you can get it, and that HDL protects against coronary heart disease, and we should push HDL as high as you can get it. However, there's a bit of a problem with this theory in that if you take people who present with a heart attack to the hospital, a significant proportion of them have actually got normal or low LDL. So this is a study of 136,000 hospitalised patients who all had a heart attack. We're plotting their LDL cholesterol against the number of patients in that particular risk group. So these are all of the patients that had a heart attack and their varying levels of LDL cholesterol. And you can see that approximately 50% of people who've presented with a heart attack have a normal LDL, that is an LDL of less than 2.5. So it's a bit perplexing. If LDL causes coronary heart disease, how is it there are some people who present with coronary heart disease who have completely normal LDLs, or in fact quite low LDLs? Taking a look at the risk of mortality associated with lipoproteins, this is the same study as I quoted before. If you have a look at the hazard ratio for dying and compare it to the LDL cholesterol, you can see that a very low LDL cholesterol is associated with approximately a doubling of the risk of dying, and that all the way up to an LDL cholesterol of about 3, you can see until you get to an LDL cholesterol of about 3, the risk of dying is increased. And then we've got a pretty flat graph until LDL cholesterol gets up to about 6.5 or 7, and then the risk increases. So there's a clear U-shaped association between the risk of dying and LDL-C, with the highest risk being in people with very low LDL-C. If we have a look at the risk of dying with HDL-C, once again we see a U-shaped pattern, if not a little bit more dramatic. We already know that low HDL is associated with increased risk of heart attack, and it's also associated with increased risk of dying. But you can also see that a very high HDL of over 2 is also associated with increased risk of dying. So stating that LDL is associated with heart attacks and therefore we should push it as low as we possibly can, and HDL protects against heart attacks and therefore we should push it as high as we can, doesn't necessarily make sense from a mortality perspective. So what happens is if your delivery van's gone out and it's delivering its cargo, in this case triglycerides and cholesterol, and it gets damaged in the process. So it has a front end collision and the front end of the delivery van becomes distorted. Well, what happens is the liver doesn't recognise it anymore, the receptor doesn't recognise it, and it gets caught out of the system. And this is what happens with small, dense LDL. So if the LDL particle is damaged, the liver receptor doesn't recognise it and it gets caught out in the system. This is called small, dense LDL, and this is the sort of LDL that we think is associated with an increased risk of coronary heart disease. So what can damage LDL particles? Well, there's 3 separate things. The first is glycation, or the addition of a glucose molecule. Glucose is pretty sticky, and in any situation where blood glucose is elevated, including insulin resistance, metabolic syndrome, or type 2 diabetes, glucose particles can stick to the LDL and damage it so that the liver doesn't recognise it. The second process involved is oxidation. So, for example, smoking causes oxidation of LDL particles, as does as industrialised seed oils. And oxidation again damages the LDL particles, so it isn't recognised by the liver. And finally, we have inflammation. So any inflammatory process increases the risk of coronary heart disease. For example, rheumatoid arthritis doubles the risk of coronary heart disease, and inflammation again is a cause of the development of small dense LDL. So if we have a look at small dense LDL, in this particular slide, you can see on the left-hand side, we've got large buoyant LDL. That's not a problem. Then we've got this small dense LDL, which is being damaged, which the liver refuses to take up to recycle. And once it's caught out in the system, it's exposed to an increasing risk of more damage, more oxidation, glycation, inflammation. And we believe that it's this LDL, small dense LDL, which ends up in the walls of arteries and it equates to the risk of coronary heart disease. So if we have a look at the risk of coronary heart disease with varying levels of small dense LDL over a follow-up of 15 years, this is a study of about 11,500 people. So small dense LDL has been divided up into 4 quartiles. The bottom blue graph is the lowest level of small dense LDL, and the yellow is the highest level of small dense LDL. And you can see that the higher the small dense LDL, the higher the risk of coronary heart disease. Conversely, if we have a look at large buoyant LDL, you can see that even though we've got 4 lines there, they don't separate at all, in that large buoyant LDL has no association with coronary heart disease. We can measure small dense LDL by doing a lipid subfraction test. So a lipid subfraction test is where all of the lipoprotein particles are separated out on the basis of their density. This is a test can be ordered by any GP. It's not covered by the MBS, so it costs about $130 and can be done performed by any lab. So if we have a look at the various particles on the far left-hand side, we can see we've got very low density lipoprotein and mid-density lipoprotein. So we're not particularly interested in those. And on the far right-hand side, we've got high density lipoprotein. If we focus our attention in the middle to the LDL, you can see this is divided LDL up into 7 different particles. On the left-hand side, we have large buoyant LDL, and from LDL3 onwards, we have small dense LDL. So you can see that this particular person has plenty of a large buoyant LDL, but also a significant quantity of small dense LDL. So they also describe what the average particle size is. Now, clearly, you would like your average particle size to be as large as it possibly can so that you don't have small dense LDL. In this instance, this person has got quite a low average particle size, and this is described as a type B pattern, which is associated with increased risk of coronary heart disease. So what are the other things that are associated with an increased risk of coronary heart disease? This is the Women's Health Initiative study, which is a study of roughly 50,000 women, postmenopausal women, followed up for 21 years. And if you look at the factors associated with increased risk of coronary heart disease, number 1 is type 2 diabetes, which increases the risk by 10.7-fold. Lipoprotein insulin resistance, which is the second thing, which is essentially small dense LDL, increases risk by 6.4-fold. Metabolic syndrome, 6-fold. Hypertension, 4.6-fold. Obesity, 4.3-fold. And triglycerides, 2.1-fold. So if you look at the top 6 associations between coronary heart disease, you'll notice that all of the top 6 are associated with disorders of glucose metabolism. So all of these have some sort of association with either insulin resistance, metabolic syndrome, or type 2 diabetes. Right down the bottom at number 7, you can see we've got LDL cholesterol with a 1.4-fold increased risk. So if all of these 6 things at the top show such an increased risk of coronary heart disease, and LDL cholesterol only increases the risk by 1.4-fold, why is all our focus on LDL cholesterol? Well, that's because the pharmaceutical industry has a $1 trillion annual business in lowering LDL cholesterol with its production of statins and other cholesterol-lowering agents. So if you look at therapeutic carbohydrate reduction, which is either a low-carb diet or a ketogenic diet, most of the cardiovascular risk factors are decreased. So we have improved control of diabetes or remission in people who are fortunate enough to get there, improved control of metabolic syndrome or resolution if we're lucky, decreased weight, decreased blood pressure, decreased triglycerides, decreased more dense LDL, and decreased inflammation. We also have an increase in HDL cholesterol, and we know that low HDL cholesterol is associated with an increased risk of coronary heart disease. So all of these risk factors improve. The outlier, however, is LDL cholesterol, because LDL cholesterol can go three ways. It can reduce, it can stay the same, or it can go up. And unfortunately, in some people, it can go up quite considerably. There's a group of people that we call lean mass hyperresponders, which, as it sounds, are often quite lean, very fit individuals, and sometimes their LDL can go up dramatically. So to put this whole conversation together in some context, I'd like to present a case study. This is Chris, who had been diagnosed with type 2 diabetes and was pretty distressed and came to see us to talk to her about how she could reverse this disease. She'd had high blood pressure for a number of years. She had blood pressure and was on 2 blood pressure medications. Her GP had started on metformin for diabetes. So she went on a ketogenic diet for 6 months and she did extremely well. She lost 11 kilograms in weight, 10 centimetres around her waist. Her blood pressure returned to normal and she was able to stop both her blood pressure medications. She put her diabetes into remission. She decreased her triglycerides, improved her HDL, and resolved her fatty liver. However, unfortunately, her total cholesterol went up to 6.9 from 5, and her LDL cholesterol went to 4.7 from 2.5. Her GP received a copy of these results, and her receptionist rang up Kate and asked her to come in to see the GP. And the GP said, "Oh my God, Kate, what are you doing on this crazy fad diet? You're going to kill yourself. Your cholesterol and your LDL have gone through the ceiling. You're at risk of having a heart attack. You've just got to stop this diet, and I want you to start on a statin." So Kate came back to see us to ask for advice. So the first thing we did for Kate was we did a liver subfraction test, and you can see that Kate's got large buoyant LDL, only a tiny little bit of small dense LDL, and overall her mean particle size is large. So she falls into a type A pattern, which is not at an increased risk of coronary heart disease. We also spoke to Kate about having a CT coronary calcium score done. So CT coronary calcium score has been around for a long time, but has probably been underused till now. When coronary arteries are damaged, as part of the repair process, calcium is laid down. And by measuring this calcium, we can have a look at whether any damage has been done to the heart, and also we can predict what future damage might happen. So it's about 5 minutes in a CT machine. It's pretty quick. It's available in South Australia for free at the Repatriation General Hospital and the Royal Adelaide Hospital. Otherwise, it costs about $250 at any of the other private radiology providers. So having a look at calcium in coronary arteries, we can see in the top left-hand figure, the heart in the middle of the chest cavity, and there's no evidence of calcium there at all. On the right at the top, you can see there's a couple of little dots of calcium. This person's got a low coronary calcium score of 48. Bottom left, you can see there's an increasing amount of calcium, and this person's got a calcium score of 203. And finally, the bottom right, you can almost see the outlining of the artery there. And this is a high coronary calcium score of 755. So Kate there is an association between coronary calcium scoring and myocardial infarction. So if we look at the cumulative incidence of coronary events over a period of 5 years, and we separate out the coronary calcium score into 4 different levels, you can see that someone who's got a very low coronary calcium score of 0 has almost no risk at all of having a cardiac event within 5 years. But as coronary calcium score goes up, the risk of having a cardiac event goes up. So by the time the coronary calcium score is over 300, there is a approximately 10% 5-year risk of having a coronary event. And similar picture for mortality. If we look at survival over 12 years compared to very different levels of coronary calcium score, And in this instance, they've divided it up into 5 levels of coronary calcium score. Up the top, we've got a coronary calcium score of 0 to 10. And you can see that we've got a coronary calcium score on that level that 99.4% of people will be alive at 12 years. But as coronary calcium score goes up, survival goes down. So by the time you have a coronary calcium score, which is exceedingly high, of greater than 1,000, there is a 76.9% chance of being alive at 12 years. That is 23% of patients with a coronary calcium score over 1,000 will not survive 12 years. So we did a coronary calcium score on Kate, and she came back with a coronary calcium score of 13.1. So Kate's still pretty confused by all of this, so we decided to put this together in a cardiovascular risk calculator. So there are lots of cardiovascular risk calculators available. This particular one is the Multi-Ethnic Study of Atherosclerosis, or MESA cardiovascular risk calculator, which is available online and you can easily use it yourself. So we put all of Kate's details in here: her age, her coronary calcium score, does she have diabetes, does she smoke, what's the family history, total cholesterol, HDL cholesterol, blood pressure, and what medication she's on. And we press calculate 10-year risk, and we come up with a 10-year risk of 2.5%. So if we take 100 people over 10 years with Kate's risk, 2.5 of them will have a heart attack in that time frame. If we were to add a statin in, we were likely to reduce the risk by about 1/3. So now 1.5% of people will have a heart attack within 10 years. So we've reduced the risk by 1 in 100. However, unfortunately, statins are associated with both insulin resistance and increasing insulin levels, and also increase the risk of type 2 diabetes. So this is a study of 1 million people in Korea, half of whom were on a statin, half of whom were not on a statin, followed for 8 years looking at the risk of diabetes. And you can see that the blue line is never statin users and the red line is statin users. And you can see there's a consistent increasing association between statin use and type 2 diabetes. So long-term statin use of greater than 10 years, especially with high-dose statins, is associated with about a 2.5-fold increased risk of diabetes. So equating that to Kate, she's got a 1 in 100 chance of developing diabetes over the 10 years. So in summary, if we put Kate on a statin, there's a 1 in 100 chance that she will prevent herself from having a non-fatal myocardial infarction, and there's a 1 in 100 chance that she will develop diabetes. That is 99 people out of 100 taking a statin in this instance will not benefit from taking the statin. Kate decided she didn't want to take the statin, and we decided we'd continue to follow her quite closely. We decided 6 monthly reviews with bloods to keep her on the straight and narrow in terms of her low carbohydrate ketogenic diet, and that we'd also repeat her coronary calcium score in 3 years. So thanks so very much for listening. I'll talk to you again soon.